out of India rather than a lack of burden of disease. I was recently there and sort of toured many of the health systems there. And I think anyone who practices realizes that the HCC burden in India is much greater than what is represented on this map. And this is a disease that is only increasing in burden in India, in part given increases in both alcohol and non-alcohol related liver disease. One of the key things and really the impetus for doing HCC screening is the fact that prognosis is really driven by tumor stage at the time of diagnosis. Here we can see a schematic from the Barcelona Clinic Liver Cancer Staging System, the most commonly used and most widely validated staging system in the world. And I'm not going to go through this in detail, but I think what I do want to point out is that those patients who are found at a very early or early stage, have curative therapies available: local ablation, surgical resection, liver transplantation, and these are the therapies that give an average survival well over 5, if not over 10 years. If we find people with larger tumor burden, whether intermediate stage or advanced stage, we have palliative therapies, whether local, regional, or systemic in nature, which can improve survival, but really don't give us that long-term survival benefit that we see with these curative therapies. So with that in mind, several professional society recommendations, AASLD, EASL, and NASL, all of them recommend performing surveillance in at-risk individuals. And we see these being defined as cirrhosis from any etiology, whether viral or non-viral in etiology, as well as high-risk subgroups with chronic hepatitis B. So when one thinks of endemic countries, this would be males over the age of 40, women over the age of 50, or a family history of HCC. We've also seen increased incorporation of risk calculators, including the PAGE-B score. But I think either way that you do this would be high-risk subgroups of non-cirrhotic hepatitis B, and then cirrhosis from any etiology requiring surveillance on a semi-annual basis. And we know that HCC surveillance is associated with improved survival. In chronic hepatitis B, on the left-hand side, you can see this evaluated from a randomized trial now conducted over 20 years ago, which showed those patients allocated to surveillance were significantly more likely to be found at an early stage and had reduced HCC-related mortality versus those patients who were allocated to no surveillance. In patients with cirrhosis, we have several cohort studies that also show a consistent association with improved early detection, curative therapy, as well as overall survival when one adjusts for the biases of these studies, including lead time and length time bias. And you can see this once again reflected in this systematic review and meta-analysis on the right-hand side of the slide. Now, of course, any cancer screening program must balance these potential benefits versus these potential harms, including physical harms, financial harms, and psychological harms. And our group has been one of the groups that has tried to enumerate these harms depicted here. But overall, I think in most patients that are at risk, one can say that the benefits outweigh the potential harms, which appear to happen in a minority of patients and appear to be relatively mild in severity. On a patient-by-patient basis, we do need to think of these individual factors which can change that balance on a patient-by-patient basis. But once again, in most patients, this is thought to be high overall value. Surveillance should be performed using semi-annual ultrasound plus AFP. So this is sort of the recommendation across most society guidelines, including the AASLD and the NASL, which recommend the incorporation of both modalities. Now, when one takes a look at the data supporting this recommendation, we see on the left-hand side the sensitivity of ultrasound alone to find HCC at an early stage is suboptimal. This pooled sensitivity across studies is only 47% to find HCC at an early stage. And you can see high sort of center variability in terms of the likelihood of finding HEC at an early stage, despite all of these being expert centers. When one adds AFP, you can see the sensitivity being higher. So the sensitivity of ultrasound plus AFP, significantly higher than that of ultrasound alone, achieving a pooled sensitivity of around 63% when one uses the two tests in combination. Now, the other issue that limits sort of surveillance effectiveness is the fact that surveillance is underused in a lot of patients. So when one takes a look at studies across the globe, we see that unfortunately only 1 in 4 patients who should receive surveillance does so. And in India, this is probably one of the biggest limitations of finding people at an early stage, is that many patients unfortunately do not receive surveillance as they should. And so I think this is one of the biggest things that we need to work on to increase early detection of HEC and once again increase the receipt of curative therapy. And as much as we talk about test sensitivity, I think it's important to remember that test adherence is actually equally, if not more important, because it doesn't matter how good a test is if nobody's using it. Now, the recall procedures for ultrasound and AFP depend on the findings as well as the visualization. And you can see here a schematic that was incorporated into the ASLD recommendations, and once again, similar recommendations existing from a nasal perspective. Those patients who have normal results can simply go back to ultrasound and AFP. Those patients who have abnormal results, a lesion greater than a centimeter, or an abnormal AFP, should go on to diagnostic testing with multi-phasic MRI and CT. And once again, you'll hear several talks on the diagnostic algorithm and the imaging features of HEC over the next hour. These intermediate categories of having suboptimal visualization and a sub-centimeter liver lesion have been sort of addressed in most recent studies, and I'll talk through really quickly some of the data that informs these recommendations in terms of next steps. So the first thing that has now been evaluated is the risk of HEC and sub-centimeter liver lesions on ultrasound. So these patients with small liver lesions on ultrasound less than a centimeter, overall, both by most recent retrospective studies as well as a systematic review and meta-analysis of the literature, find that the risk of HEC in contemporary cohorts is low. And overall, when one takes a look at the risk of HEC in these patients with these sub-centimeter ultrasound lesions, the risk of HEC is on par with that of somebody with cirrhosis not having any liver lesions. And so right now, the recommendations are for these patients to stay on ultrasound, and this can be done either at a 3-month interval or a 6-month interval. I think either one is reasonable. I think when one takes a look at diagnostic practices, unfortunately, diagnostic imaging is performed in a reasonable proportion of patients. Up to 1/3 of patients go on to receiving a diagnostic CT or MRI, which is likely unnecessary. And so one of the things that we can do as a radiology and hepatology community is making sure, given the low risk of HEC, that these patients with a sub-centimeter liver lesion on ultrasound simply stay on ultrasound at that point, and only those patients with a liver lesion 1 centimeter or greater go on to diagnostic imaging. The other thing that's worth noting is the importance of assessing visualization on the ultrasound. We know that patients have a reasonable risk of having suboptimal visualization being observed consistently across studies in about 20% of patients. And we know that this risk of having suboptimal visualization is higher if patients have obesity, particularly central obesity, as well as non-viral liver disease, including alcohol and metabolic dysfunction-associated liver disease. And as I've mentioned, these are common comorbidities in an Indian population, both having obesity as well as having non-viral liver disease. And so suboptimal visualization is likely common when one is performing ultrasounds in an Indian population. So I think the key thing here is, what is the impact of poor visualization or suboptimal visualization? This was a study that we recently published looking at the association with these Lirads visualization score B and C with subsequent sensitivity and specificity. We can see that visualization score B is moderate limitations, and this is nicely defined by the ultrasound Lirads group. And then visualization score C is poor visualization. And it's really when you get into this score C that you have a significant drop in your sensitivity from around 70-some% down to the 20s. And so one can argue that those patients with a visualization score of C should instead have other screening modalities, whether that is a screening MRI or something else, but clearly the ultrasound is not working in those patients with visualization score C. Patients with visualization score B are these intermediate groups, and there I think the sensitivity of ultrasound for visualization score B appears preserved. However, one needs to look at how those patients declare themselves over time. There's a portion of those people who will then have better visualization the next time. There are a subgroup who will have worse visualization, so we'll go down to visualization score C on repeat exam. And I think, once again, depending on how those patients declare themselves over time, one can then determine if they should stay on ultrasound or instead transition to a different screening modality. When one takes a look at the different screening modalities that are undergoing validation, we see multiple blood-based strategies, whether those are protein-based biomarkers such as GALID, including AFPL3, AFP, and DCP. There's also one which includes simply AFP and DCP combined with gender and age, called GAD. And then there are also more sort of nuanced blood-based biomarkers like Oncoguard liver, Helio liver, of which we just saw the results at ESMO earlier this year. And then we also have imaging-based strategies, including either MRI and abbreviated MRI. I'm not going to go through these in detail, given sort of lack of time, but I think the thing that's worth noting is that these are undergoing further validation. There are now randomized trials comparing abbreviated MRI to ultrasound, as well as randomized trials comparing GALID to ultrasound. And so I think we will have further data over the next several years about how these different modalities compare to our current standard of care, ultrasound and AFP. And I'll end my talk with sort of a sort of proposition or maybe a push in terms of the way we should be thinking about this field in terms of surveillance, is perhaps we should be moving away from one size fits all. Maybe the answer isn't ultrasound plus AFP in everybody, nor is it abbreviated MRI in everybody, nor is it a blood-based biomarker in everybody. But maybe the answer is instead that it's a mishmash, that there's the best test for each individual patient in front of us. And so this was a recent cost-effectiveness analysis that we conducted and published, looking at these different types of strategies in terms of one-size-fits-all, risk stratified, where you just take a look at somebody's risk and assign a strategy, and then this precision surveillance, where you assign the best test based off of one's risk as well as individual characteristics that can influence test performance. And as one would imagine, precision surveillance was arguably the most complex, but was the most cost-effective and the most effective at finding HCC at an early stage. And so, not to say that this is what we should be using today in 2024, but more so sort of a look forward in terms of where I hope that we are in over the next several years as we have these other modalities further validated. So with that, I summarize that HCC surveillance should be performed. It's supported by a randomized trial in patients with chronic hepatitis B and several cohort studies in patients with cirrhosis. This is clearly very important if we want to maximize benefits, including early stage detection and curative therapy receipt, and currently has acceptable harms based off of false positive and indeterminate results. As I mentioned, the current standard of care is ultrasound plus AFP, and it's important that we think through the appropriate recall strategies based off of accurate communication of ultrasound findings as well as visualization. And finally, there is a role for emerging imaging and blood-based biomarker strategies, particularly for these patients in whom ultrasound has visualization limitations, although we are awaiting further data on knowing exactly who should receive what emerging strategy in these patients. With that, I'd like to thank you once again for the invitation. Liz, I don't know if you want me to take a question or two now, or if you'd rather just move on and then.
No, I think there are a few. I think there are a few questions. So let me read a few to you before you run off. Okay. Take care of your patients. Thank you so much. That was a fantastic conversation starter. So let me read some of the questions. I don't know if you can see them. One was, what is the cancer risk? What is the cancer risk in non-enhancing sub-centimeter nodules seen on MRI, not on ultrasound? We'll have to say that question for our radiologist later. And then there's a question: is there a role for PIVCA in screening? Can PIVCA rise in the range of 6,000 in giant hemangioma? I don't know.
Yeah,
I don't know about PIVCA.
Yeah, so PIVCA, is the other name for PIVCA is DCP. And so, this is one of the emerging biomarkers. So right now it's ultrasound and AFP. There are several studies that show complementary value to DCP or PIVCA, as well as complementary value to AFPL3. And these have now been incorporated into these biomarker panels, whether you use GAD, gender, age, AFP, and DCP, or you use GALAD, gender, age, AFP, AFPL3, and DCP. I think at least the data that exists suggest better value using panels rather than individual biomarkers. So, AFP and DCP interpreted in isolation. So I think that in general, I think we're starting to realize that these other biomarkers are useful, although we are awaiting better validation to know how this competes against ultrasound and AFP. So I don't think we know the full answer, but I think it's promising. So I think this is sort of one of the emerging modalities that I'm most excited about. Liz, I'll just, if you don't, go ahead.
Yeah, I just wanted to ask you about contrast-enhanced ultrasound and whether you think in the future that will have a role in the screening process or more in the diagnostic process.
Yep. Yeah, so I think contrast-enhanced ultrasound, so, the issue, so I think contrast-enhanced ultrasound is great. I think it's promising. I think it has a role. I think that the way that I personally see contrast-enhanced ultrasound incorporated into screening algorithms is that you would screen using a non-contrast ultrasound. And if you find a liver lesion, you can then reflex to doing the contrast ultrasound that same day. So you wouldn't start with a contrast ultrasound in terms of doing the screening. You would start with, a non-con ultrasound and only do the contrast if you find a liver lesion. I think it's much more efficient, given the fact that you can give the contrast load and watch it through the liver lesion, rather than doing sort of contrast multiple loads going through the entire liver. I don't think we have great data showing that contrast use increases sensitivity for liver lesions that are missed on non-contrast ultrasound otherwise.
So that might also increase compliance. If their patient's already there, then you can start to pull them into the system at that day as well. So now I think
and also you minimize the risk, you minimize the need of that patient coming back in for another day, getting a CT and MRI for non-specific liver lesions that are just regenerative nodules or other liver lesions. And if you find a Lirads 3 or Lirads 4, yes, I understand you need to follow that patient, but you then don't need to have that patient come in for the CT MRI right away. They could still come in, in 3 to 6 months. So you save that patient another visit, which is particularly important for patients that are working or have significant barriers to coming in for visits.
Excellent point. Sanal?
Yeah, so I had a question, non-contrast MRI, like as screening, instead of it's a variant of abbreviated MRI, where we do high-res diffusion, T1, T2 weighted imaging, and in an opposed phase. Because in India, the cost of MR is more because of the contrast, rather than the person cost. I think Amit knows that. So what's your take on that? And the second question is that somebody has said that can we use like CT or MRI to characterize on ultrasound? and contrast. And also there is another contrast which is being used in Japan. What's your take on that? And
Yeah.
again, abbreviated MRI, what are your inputs? Because
Yeah.
at my center, clinicians have started using it in select cases.
Yeah. I think the abbreviated MRI I think is a very interesting modality. So, and there was a recent study published out of Korea actually comparing non-contrast abbreviated MRI to ultrasound. And in that study, it looks like non-contrast MRI actually has numerically higher sensitivity for early stage detection versus ultrasound. So I think it's highly promising. I think, the one thing that I'd say is that we don't have good, large studies conducted over time in diverse patient populations. And so I think that, do I think it's an answer? I do think it's an answer that will move forward. Do we know in whom it works, whom it doesn't work? I don't think we know the answers to that. And do we know what the downstream false positives, the workup will be? I don't think we know the answer to those questions. So I think the issue is that the studies that are often done upfront overemphasize benefits and they don't actually evaluate these downstream consequences as well. However, the available data are extremely promising, and I would be shocked if we don't see some form of abbreviated MRI in the future incorporated into some patients. However, I mean, like India has over 1 billion people, and when you calculate this out in terms of cirrhosis percentage, you take a look at the number of people who need HCC screening is enormous. We have trouble incorporating a very simple and cheap test like ultrasound, let alone now talking about squeezing all those people into an MRI machine. So I think this is a niche answer. I don't think it's the answer for the global population. And I don't know, I think it depends on your center. But, some centers in India can get an MRI very quickly. But I can tell you in our center, right now, I wait 2 weeks to get a diagnostic MRI. And I don't mean to like bash our university because honestly, I'm not the only one. When I said this, I mean, the other universities also are like, yes, we also wait 7, 10, 14. Other centers are waiting longer. Not to mention, there are now a radiology shortage, which I'm not going to get into, but like, I mean, like the length at which we wait to get our read for an MRI also adds days. So like, I'm going to go see patients in sort of 5 minutes or 10 minutes. And I know that there are 3 patients who I'm seeing in clinic today that don't have their MRI read, despite it being done a few days ago. So I think it's the other thing that, like, I just think we have to think about this capacity issue and sort of the reads. And one other thing that I'd say about the MRI, and once again, I do think this is a promising modality, but I see people with cancer that I have to follow MRI indefinitely, right? Because they have a very high risk of having HCC. And I can't tell you how many patients, when they're on their year 4 of their MRI, are like, doc, do I really need to continue on this MRI? I really don't want to get another one. And there's these negotiations which happen like, okay, we won't do it in 6 months, we'll do it in 7 months. Let alone a cirrhosis patient who you've never had cancer. You have a 1% risk of this happening. Them getting, even though it's non-contrast, it's an MRI. It's still a very small tube where they're stuck in it for whatever it may be, 15 to 20 minutes. So I think it's a niche answer, not the answer for everyone.
But I do think, no, I think that's interesting. I think you made a really good point about, and I'll let you go, but your perspective from the patient. What the patient, it's a matter of capacity, but it's also a matter of getting the patient in the door and interviewed, examined, and scanned. So we have to think about the patients and their various characteristics and how compliance is a huge part of it, and getting them to partner to do this process and be able to manage that in their own lives is important. And I think that's the part of the piece of the equation that I think you've highlighted that we need to consider, and giving them options is actually helpful. And patients want to have that ability to have some control over their care and not just the expense, but the inconvenience and psychological burden of that. So I think those points I think are very important, and that we do have a more wide array of options will be very important moving forward, and selecting the right patient for it.
And Liz, I think this goes back to like why I think that it's going to be this precision surveillance strategy. That if I can risk stratify people, which we are starting to have some biomarkers, we're starting to have some clinical characteristics, and I can tell a patient, look, you don't have a 1% risk of developing HEC this year. You have a 3.5 or 4 or 5% risk of developing HEC every year. And I know that the other modalities, like ultrasound's going to not work well because you're obese and you have MASH cirrhosis, but you have a high risk. Then we're like, okay, you're somebody who would individually benefit from this, and that conversation is very different than somebody who ultrasound would work well or GALID would work well, and they have a low risk of HEC. I think those risk benefit ratios are different. So I think good news is we're making progress. We're going to have better modalities around the corner. It's just a matter of which ones and who.
Thank you so much, and thank you for your participation. And so he's going to sign off. Thank you so much. And then we're going to move to Dr. Victoria Cherniak, who's also on clinical today too. So she's going to stay with us for as long as she can and present her 2 back-to-back talks, giving you an introduction and overview of CT-MR Lirads algorithm and how it's changed in recent years. Thank you, Victoria.
Thank you, Liz. And first, I'd like to briefly say thank you, Liz and Sonal and Shaban, because they've put so much work into creating this webinar.